So we are live now, ma'am. Okay. So
Okay,
we'll start
okay,
in another 1 or 2 minutes.
okay.
A very good morning to one and all. I'm your I'm your moderator for today, Dr. Raghavendra, the lecturer in the Faculty of Dentistry. So today we are back with another webinar on the title, The Platelet Concentrates, a Concentrated Magic. To present this interesting topic, we have Professor Betsy Sarah Thomas with us, a periodontist and oral implantologist by profession with almost 30 years of experience in academics. Professor Betsy is involved in research and teaching and training of undergraduates and postgraduate students. She did her undergraduation and post-graduation studies in Manipal University, India, and joined the same institution as an assistant professor, rising to the position of professor and head of the department. She has published more than 50 research papers in peer-reviewed national and international journals and has authored 6 books. She has been involved in PRF-related research in biomaterials for soft tissue and hard tissue healing and also their growth factor release kinetics. She is a fellow of the Indian Association of Oral Implantology. She is a professor in the Department of Periodontology at Masa University, Malaysia. So before we start with the presentation, if you have any question, leave your comment in the inbox. We will answer you at the end of the presentation. Without any delay, I would like to welcome Professor Betsy Sarah Thomas. Thank you, ma'am, for joining us. Please proceed with your presentation, ma'am.
Thank you, Dr. Raghavendra. Okay, good morning, ladies and gentlemen. Thank you very much for tuning in for this webinar. As Dr. Raghavendra said, this is part of a series of webinars from the Faculty of Dentistry, Masa University, Malaysia. Ours is a private medical university situated at Bandar Saujanaputra. Our university earned its spurs as an education hub. Thanks to the quality of education we impart, the world-class facilities that are provided, and the high placement rates of our graduates in all fields of education we offer. So coming to today's topic. As you know, this webinar is about platelet concentrate. So before I start, I would like to tell you why you need to know about this platelet concentrates. We all talk a lot about healing. What is this healing? It is actually a process of returning to health, the restoration of a structure and function of an injured or a diseased tissue. Now, the ability of an organism to repair or regenerate a tissue is a definite advantage for survival. And this requires a perfect interplay of several orchestrated events. Now, any disruption in these wound healing phases can lead to abnormal wound healing or a chronic wound that is going to be there. Now, we require cells, hormones, proteins, and growth factors. Now, the ability of these polypeptide growth factors to regulate the events of healing like proliferation, chemotaxis, differentiation, etc., have been investigated by several authors. Now, the search for an ideal material in order to promote healing has led the scientists to focus on these platelet concentrates. But at the same time, you will find that there are a lot of questions that has been raised against the clinical effectiveness of this platelet concentrate. So from the data what we are having today, what we need to understand is that if we continue to accept the platelet concentrate therapy consciously or unconsciously, in the present form, it may soon fall out of use. Therefore, one must obtain clear evidence on the functionality of this platelet concentrate therapy. And for that, what we need to keep in mind is that in order to prove or to have a good clinical result, one should use an ideal protocol and an adequate product. Now, before we go into the deeper aspects of platelet concentrates, let us look at the cells which are present in them. Platelets, said to have a hemostatic role, it can act as a scaffold for tissue regeneration. It helps in stem cell binding, and it is also known for its growth factor concentration. And this gave a promising scope in periodontal regeneration. Now, today, let us together try to discover more about this platelet concentrate. Is it a concentrated magic? Now, when we talk about this platelet concentrate, there are a lot of questions that come to our mind. What are the different types of PRF? Which is the best machine to be used? Which is the best centrifugation protocol? And so on. Now, the learning outcome that is expected from this session would be that you are able to understand different types of platelet concentrates. You are able to recognize the factors that can affect the platelet rich fibrin activity. You are able to recognize the shortcomings in the current clinical trial and also hope to give you certain tips which can help you in your decision making. Now, the secret behind the use of platelet preparation lies in the fact that the alpha granules which are present in the platelets are reservoirs of growth factors, and these play an important role in the hard tissue and soft tissue repair. Now, these platelets contain biologically active proteins which can create a chemotactic gradient, and this is responsible for the cell recruitment, differentiation, and can help in the healing and regeneration. Now, preparation of platelet concentrate uses a centrifuge which creates a centrifugal force that separates the substances of different densities when it is subjected to centrifugation. Now, separation of substances that happens during this centrifugation depends on the speed, radius of the rotor, duration, and also the angulation of the rotor. Now, let's look at the evolution chronology of the platelet concentrates. Now, the journey of platelet concentrate started in 1970s. Later, in 1990, Anito et al. Formulated a product by utilizing an anticoagulant, and they coined the term platelet-rich growth factor. Now, this product is no longer in practice today. Now, if you closely look at the literature, you will find that it is stated that this product was misnamed at that time as PRF, but actually it produced a PRP product. Now, later in 2000, Joseph Chokran introduced platelet rich fibrin and he labeled it as PRF. This was an important turnaround in the evolution of the terminologies. Now, if you were to look into the 1970s, that is an era of fibrin glow, we find that this was accepted during that time because of its positive effect on the tissue repair and regeneration. But its use was limited owing to its complexity and the cost of production. Now, looking at the growth factor era, this was an era where PRP and platelet rich growth factor, that is PRGF, was in use. Now, PRP was used as a promising reservoir for growth factors, which could facilitate wound healing and regeneration. Now, the PRP that was obtained was in a liquid state and had to be converted to a solid form for a clinical use. Now, this conversion was achieved by the usage of a bovine thrombin. Now, this also resulted in the rapid diffusion of these growth factors at the surgical site. Now, the concept of regeneration through growth factors tempted many clinicians to use this product at that time. So, after the use, there were a lot of problems that were reported. One was technique sensitivity, it was time consuming. Another concern on transmission of infections. What we need to understand here is that the term PRP was used to name all kinds of preparations and techniques without proper characterization of the content and architecture, which means that the preparation protocol lacked a standardization. And this has led to a lot of controversial data, which means that there was a state of confusion that led to a general feeling that the PRP is not useful in the clinical setting. And as a result, this PRP started slowly disappearing. Next was the plasma rich growth factor, which was developed by Anita et al. And this was characterized by elimination of leukocytes in order to suppress the pro inflammatory effect. Now, the fibrin leukocyte era was an era where Chokran and co workers developed a novel technique by eliminating the use of this bovine thrombin. And this was known as second generation platelet derived biomaterial. Now, looking at the preparation, this preparation of PRF is a simple procedure and used only a single stage centrifugation compared to the PRP. Now, during centrifugation, a centrifugal force is uh, directed towards the bottom of the test tube, and at the same time, you will find two other forces that are acting opposing to it. So during centrifugation at 3000 rpm, a high amount of centrifugal force is generated, and this exceeds the other force. So as a result, the RBCs which are having higher mass is pulled towards the bottom of the test tube. And WBCs, platelets, and plasma, which is said to have a lower mass, is collected at the top. So eventually, this part excludes the RBC from coagulation, and the clot thus formed is called as a PRF clot. So if you look at the test tube, you will see that the lower portion is the RBC, followed by which you have the buffy coat, and then the fibrin, and then acellular plasma. Now, microscopically, this constitutes a three-dimensional structure with a dense polymerized matrix. You have a red part where RBCs are entrapped in a relatively immature fibrin network, a buffy coat area, that is the junction between the red stub and the fibrin body, where you find numerous platelet aggregates. Now, this is an area of interest to the clinicians because you find more amount of platelets, and this area is rich in growth factors. Now, platelets are concentrated in this area, that is the first few millimeters after the red part, and you find that these are constantly decreasing as the distance from the red end increases. Now, the key elements of PRF includes the fibrin, platelets, leukocytes, and the stem cells. Fibrin, as you know, it provides a rich supporting matrix. The platelets are known for its growth factor, leukocytes, antibacterial action. The stem cells can help in the neovascularization and regenerative potential. Now, what we need to understand is that The healing and reparative process is totally dependent on the initial mechanism of hemostasis and wound healing. Now, in the concept of PRP, it actually uses three fundamental principles and biologic process of healing. The first principle is related to phase one, that is the hemostasis phase, which results in the formation of a fibrin matrix. It acts as a scaffold and helps in the recruitment and migration of the cells. The second one is an inflammatory phase. This is characterized by recruitment of cells to destroy the bacteria and also to remove the debris followed by that. Also have platelets that secretes growth factors which can enhance the healing. Now the third is similar is something which we call as a proliferative phase, wherein you have angiogenesis, and it can also helps in the stimulation of endothelial cell recruitments. As I told you earlier, platelets, they play an important role in the growth factor release, can stimulate the growth and the cell morphogenesis. The next important cell is the leukocyte. It is said to have antibacterial action. Now, this can also play an important role in the in stimulating the defense mechanism. Now, what you need to understand here is that activation of leukocytes in the PRF can result in degranulation, which means that there is a release of high number of inflammatory cytokines. Now, this itself can kickstart the healing process of wound healing. Next is the role of fibronectin. Now, this play an important role in the recruitment of cells to that area. The monocytes, they can coalesce to form giant cells, and this is also responsible in regulation of the immune response. Next is the role of fibrin. We know that fibrin uh, is deposited in an area where there is a wound. Now, actually, this deposition of fibrin by us gives a positive feedback. That is, normally, as I told you, normally the body tries to deposit fibrin in that particular area. Now that we have placed it, the focus shifts to a second phase. So that, which means that we are reducing the time that is taken for these events, and thus it can reduce the time taken for all these inflammatory responses. Now, the studies on the tissue engineering results obtained from LPRF has shown that there is a slow release of growth factor from this product. Now, what we need to understand is that the presence of activated cells is what makes the PRF to be considered as a real tissue. And this concept is used in the tissue engineering approaches. And hence, it is called as leukocyte driven tissue engineering. Now, one of the biological signature of LPRF is its ability to release the growth factors. Let's have a look at the biological actions of this PRF. This is a physiologically polymerized matrix. Now, the lack of RBC in this PRF, that is, we don't place the clot portion in the wound area, this can reduce the phagocytic burden on the WBCs. Next is the role of the growth factors and matrix macromolecules, which can play an important role in the healing. Now, this is a table which compares PRP, PRGF, and PRF. Now, if you look at this, we find that in the preparation of PRF, anticoagulants are not used, which means that a biologic process of clot activation is utilized here, which is usually an intrinsic pathway. Now, in this PRF, the growth factors get entrapped in a meshwork, and there is a slow release of these growth factor, which is sustained for a period of 7 days. That is something like a continuous slow release or something like that of the concept of drip irrigation. So this PRF has got is said to have much more advantages than the PRP, because in PRP you are using an anticoagulant, so which is playing a role in the clot activation. So it is not the natural way, and the growth factor release is said to be immediate. Now, regarding the use of PRF, there are various reports in the medical literature which highlights the effect of PRF on wound healing of chronic ulcers, infected wounds, etc. And this was something which we got interested in it. These are the few areas where we have worked with PRF. Now, PRF was used as a palatal bandage after harvesting a free gingival graft. Now, the healing was assessed in terms of color and contour, and we found that there was a complete healing after 21 days, that is, in terms of color and contour. It also used in cases of recession in treating both multiple as well as single recessions. Although we didn't find any added benefit regarding the coverage, there was definitely an improvement in the gingival biotype. This was also used in the treatment of infrabony defects, and the results showed that there was an improvement in the clinical outcomes when this was compared with open flap debridement. We had also used this in case of extraction sockets as a socket preservation therapy. It showed very good healing, and the patients also reported less pain and discomfort. This was a case wherein we had used a sticky bone concept. That is, the PRF was mixed with a bone graft and it was placed in the defect. We also tried to cover this area with the help of a platelet fibrin clot, and this was pressed against the area with the along with the flap itself, so that we didn't want this exudate to be collected outside. It showed a very good results. After 1 year, we had placed implants on the adjacent edentulous area. Now, if we were to talk about the limitations of PRF, yes, limited volume is one of the problem, as this is obtained from the autologous blood sample. So one need to really quantify the amount, and you need to be sure how much of the material is required depending on the area where you are going to use. The second is related to the quick handling properties. That is, the technique depends on the speed of blood collection, the transfer to the centrifuge, and also immediate use. The third aspect is this is specific to the donor, which means that this fibrin matrix contain immune cells and all the highly antigenic plasma molecules. Hence, this is very specific to the donor. The next one is storage for a longer duration is not advised. That is, the shrinkage and alteration, it can result in the shrinkage and alteration in the structural integrity of this membrane. Dehydration can result in decreased release of growth factors, and this can also affect the leukocyte viability in the tissue. Now, the studies have shown that the cell distribution in the product depends on the centrifugal force. So, today we have numerous techniques that have been developed to optimize the different ratios in these fibrin matrix. Now, these are the key parameters which you need to consider when you are thinking of preparing a platelet concentrate. The first one is related to the preparation kits and the centrifuge. You need to look into the time that is taken for the preparation, the size of the centrifuge, the complexity, and definitely the practical characteristics of the technique and the centrifuge. The second aspect is related to the cell switching, that is the platelets and the leukocytes. How much of volume of material can you get with this process? What is the amount of cell distribution and how long these can be preserved? The third aspect is related to the fibrin, the quality of the fibrin polymerization, etc. Now, this is a classification that is given by Dohan in 2009. This classification was given based on the fibrinogen content of it, the leukocyte and the fibrin content. And he classified as PPRP, PPRF, LPRP, and LPRF. This is the most accepted classification today. We'll come to this in the later part of my presentation. Now, Chokran further modified his PRF, that is, we are talking in terms of LPRF, to produce APRF and IPRF. There are various protocols that has been advised regarding this. Now, Gahanti in 2014 used a protocol wherein 1500 RPM was used for 14 minutes. Now, the product showed there is an increase in the neutrophils and macrophages, and another observation was that more granules were found at the Buffy coat interface. Next was Kobashi et al. She modified platelet rich fibrin, that is, this advanced platelet rich fibrin, in such a way that the protocol was changed. That is, she used 1300 RPM for 8 minutes and said that this less time or decrease in the time and decrease in the force can increase the number of cells. And this was preferred because there was a better growth factor released from this product. Next was the IPRF and the titanium PRF. Now, talking about this injectable PRF or the IPRF, this is obtained when a protocol of 700 RPM is used. Now, in IPRF, the separation of blood components usually happen in the initial 2 to 4 minutes. Now, here a plastic tube is used. Now, sorry, we need to know that this plastic tube, these are hydrophobic in nature, and this does not activate a coagulation process. Now, when the sample is subjected to an RPM of 700, the plasma containing platelets, clotting factors, etc., get collected at the top in the first 2 to 4 minutes itself. Now, this is collected and this is mixed with a graft to form a gel putty-like consistency. Now, the graft that is obtained is in a good workable consistency, and it also leads to a decreased leaching of this material as this is a tightly encapsulated tissue. Now, another advantage of this is that when you place this graft in the defect area, there is a direct access to the growth factors. That is, the growth factors can be released directly from this graft material to the site. Next is a PRF lysate. This is a relatively new application and is a very good source of a lot of growth factors. Let us look at the status of the clinical trials today, and let's see what are the lessons to be learned from this. As I told you earlier, Dohan's classification of 2009 was an attempt to actually distinguish the various platelet concentrates. Now, he used three parameters. that is preparation process, pharmacological process, properties and characteristics of this material. Now you should understand this is a widely quoted classification in the literature. What we also need to know is that Chokran's PRF was the only platelet concentrate that was included in the category of LPRF. At that time, as the popularity of this product grew, a lot of researchers got interested in it. And you find that there are a lot of publications followed by this. But however, none had applied the exact criteria as described by Chokran. This was a finding in the later part, which means that the publications incorrectly use the term LPRF and Chokran's PRF, even though they didn't use the exact method. And this could be attributed to the incorrect results and might be responsible for the assumptions. Now, let us look at the factors that can affect the preparation or what was lacking in the previous researches. The first and foremost thing is the failure to use a specific centrifuge and a specific RCF, that is relative centrifugal force. Lot of emphasis was given on the uh, time and the speed, which means that there was an underestimation on the effect of this RCF. Now, relative centrifugal force can be defined as it's the amount of accelerator force that is applied to a sample in centrifugation. Now, this can depend on the width of the width, the RPM, the tube angulation, etc. Now, what we need to understand is that the radius of the rotor is very critical to the process of producing a specific RCF. Now, only those processes where the RCF and rotor radius are identical are comparable. So, which means that any deviations from these criteria can result in inaccuracies. So one cannot assume that all centrifuges that are used for the production of LPRF and which is spinning at 3000 RPM will produce an RCF of 400 G. Now, this is a concept which was explained by Myron et al. And Gahati in 2019. It says that when the sample is subjected to centrifugation, it is exposed to a lot of centrifugal force. The RCF, that is the relative centrifugal force, is different at the bottom, at the top portion of the test tube, and also in the area where the clot is being formed. Now, this can affect the movement of the cells within the tube. So, one of the one of the confusions that has been created in this field over the years is that various authors have reported G force at different levels. So, based on the present study or the recent studies, it is shown that the maximum radius has to be considered in order to calculate the relative centrifugal force when you are preparing PRF, which means that the bottom portion of the tube need to be considered. Now, let me just try to just explain the calculation here. We allocate the values of RCF and radius in the formula. Then the RPM is set to be 1725. Now, if you blindly follow the initial RPM, that is 3000 RPM, then the RCF in this machine is going to be very high, which means that all the cells will get excluded from the clot. So what you are going to get, the final product is a pure platelet clot rather than a platelet rich fiber, right? So that explains the importance of this RCF. Next is the intrinsic characteristic features of the centrifuge. This can affect the weight and size of the clot. Now, there are a lot of devices that are found in the market today with very significant difference in terms of vibration. Now, vibrations, these can be perceived by just hearing them or even by placing a hand on the centrifuge. Now, this is an area where not much studies are being conducted. Now, the research article that had come out in 2010 by Dehan et al. Has shown that the high vibrations can result in damage to the cell content. Now, his study reports on the variations in cell damage and self morphology point towards the fact that there is much, uh, there is more to it than just the RPM, RCF, and the time, which means that a lot of emphasis was given on the vibrations. Now, the damage which was observed has raised a concern on the biological and clinical potential of this product. It said that the damaged cells can release inflammatory mediators. We know that when we talk about LPRF, it has got a property of preserved cell content and it is said to regulate the inflammatory process. So now the question is, when you have a damaged cell, can the effect be the same? Logically, the answer would be no, right? Now, this is a study that was published uh, in 2014. They have used it for the preparation of LPRF by using four different centrifuges. Now, the hypothesis of the study was that the mechanical vibrations might be responsible for the differences in the product that is produced. Now, the results showed that the product was not identical in terms of weight, volume, architecture, and cell content. Now, these observations have led to a considerable debate in the way how PRPs and PRF are produced and tested, and gave a lot of emphasis on the quality of the centrifuge as this can directly impact the architecture and composition. Now, this observation may point out a major flaw in the large quantity of publications in this field. Now, this is based on the tube angulation concepts. The horizontal tube angulation concept was put forward by Myron et al., stating the advantage of this and questioning the others' protocol. Now, they stated that on a fixed angle centrifuge, the platelets, WBCs, and RBCs usually accumulate at the side of, that is, the back walls of the tube. And this leads to improper separation and the leukocyte concentrations. Whereas when you're using a horizontal centrifuge, the cells separate much more efficiently throughout the entire tube, and this leads to a better layer separation and also favors the cells to be evenly distributed throughout this PRF clot. Now, in Remy's centrifuge, we use a swing out design. That is, it is not fixed. It allows the tubes to swing out from the vertical resting position to something like more of a horizontal. The next controversy was depending on the next controversy was on the type of test tubes that were used. Now, if you look at the initial studies, you find that PRF was prepared in the plain glass tube, which activated the intrinsic coagulation pathway. Now, later on, you will find that there was the restrictions in the supply of this plain glass tube tempted the clinicians to use the other types like non-coated plastic tubes, chemical coated ones, silica coated ones, and the titanium tubes. Now, this report is based on the study that was published on the effects of two types of tubes, test tubes, that is the glass test tube and the silica coated tubes. Now, they say that the sample, when in a glass tube, when subjected to centrifugation, the cells were found to get accumulated or pressed more on the distal side of the walls. And this effectively activated the coagulation cascade. So the result or the discussion part, they have said that the initial contact occurred on the distal surface, and so the distribution was also seen more on the distal side. There was no uniform distribution of the cells. The next was an observation in the silica coated tubes, which said that these silica microparticles are easily detached from the inside of the wall, and these get suspended in the blood samples. Now, these particles activate a coagulation reaction, but the fibrin that is formed is of a homogeneous nature. Now, the question that is here is there a health concern? Now, the silica coatings on the glass tubes and plastic tubes have raised an issue of a possible health hazard due to the unavoidable silica contact. Now, these silica particles will get detached from the side of the tubes, remain suspended in the product. Thus, it can pose a risk of these particles reaching the patient when used. Now, silica particles are also shown to cause apoptosis of the cells, and it is also can result in the cell proliferation. I mean, can affect the cell proliferation. Now, titanium PRF, this was introduced by Tunelit et al. This was based on the hypothesis that titanium is more effective in activating the platelets. And they said that the fibrin that is formed by this protocol seemed to be of more tightly woven, and it is much more thicker than the LPRF. And they said that this could remain in the tissue for a much longer period than the LPRF, and said that the release, this can also indirectly affect the release factor. Now, talking about injectable platelet rich fibrin or the IPRF, this is a second generation biomaterial which is prepared in the protocol of 700 rpm for a period of 2 minutes. The IPRF that is obtained, or which is in a liquid form, can remain in this form for around 15 minutes. After that, it coagulates to form a PRF clot, which is rich in growth factors, and it is studies have shown that the release rate to continue for a period of 14 days. Now, sticky bone, yes, it is a concept of mixing autologous fibrin glue with a bone graft to obtain something like a sticky a mass, and this was called as a sticky bone. This was put forward by Sohan et al. In 2010. Next is the concentrated growth factor, which was put forward by Saki et al. In 2006. This product was prepared with a specially programmed cycle, which resulted in a fibrin matrix which was much more denser compared to the LPRF. Now, it had a high tensile strength and stability. There are various functions that has been reported with this concentrated growth factor. It is said to be used as a fibrin tissue adhesive. It's said to accelerate osteogenesis. It is also said to improve the stability of the wound that is required for the attachment of new connective tissues to the root surface. It also helps or promotes epithelial, endothelial, and epidermal regeneration, and is also said to have antimicrobial properties because of the presence of the leukocytes. Now, this has been widely used in treatment of multiple gingival recessions, and it showed very good results. Now, having said this, let's look at what is the present status of these platelet concentrates. Now, from the cost effective point of view, this has been excessively used by a lot of clinicians, but not much importance has been given to any standard protocol. And today we do not have any randomized controlled trials to compare the effectiveness of these protocols, and no validation by independent clinical trials in order to claim the superiority or inferiority of this product. So the conclusion would be we cannot have any, we cannot say one is preferred over the other. I would like to give you certain tips which might help you to overcome certain problems which you might encounter during your preparation. The first one is always go for a machine with a programmable RCF. Of course, because we don't have any evidence to justify one centrifuge is better than the other. Second is a low speed centrifugation is used if you want a high concentration of the cells and the growth factors. Now, high RCF can result in a more resilient and a fibrin clot. The volume of the PRF that is obtained can depend on the volume of the blood that is withdrawn. Now, always try to retain a small zone of RBC on the PRF clot. That is, the adjacent area is of great importance to us. Now, certain tips which can help you in the PRF quality optimization is that always make sure that your centrifuge tubes are filled equally. Balance the rotor properly so that every tube must have an opposing tube. Do not balance the vacuum tube filled with water, as the distribution densities will be incorrect. Now, always ensure that uh, the mass is always balanced to the nearest zero point 0.1 grams. The next is that any vibrations or unusual sounds you hear, make sure that you stop the operation immediately. Now, the initial vibrations which you may notice at the time of your start of centrifugation can, to a certain extent, be minimized by just holding your hand on the lid. The third is never leave the centrifuge until you are certain that it has reached the operating speed. Now, something I would like to tell you about the PRF membrane is that after preparation, preserve it in a wet serum environment. During preparation, a gentle, slow, homogeneous pressure is used in order to prevent squeezing out of all the serum from this membrane. Now, this gentle method avoids extracting and losing of significant amount of platelet growth factors. Now, this was a comparative evaluation of the growth factor kinetics from a PRF clot and membrane, which we had conducted. The results showed that there was the mean concentration of transforming growth factor and platelet-derived growth factor was higher in the PRF clot compared to that of a membrane. Now, the conclusion was that this significant amount of growth factor was lost during the compression procedure. So, it is suggested that the liquid which is lost during the compression procedure, is preserved and should be used for conditioning the surgical area. Now, another suggestion was that the, the membrane can be prepared by compressing the platelet rich fibrin directly at the site in order to preserve the maximum growth factors from the serum. Having said this, I would also like to mention something on the old and the new concepts on platelet concentrates. In the physiological condition, the main release of growth factors was found to be after several hours. So it was thought that this PRF could be used after a long time after preparation, provided this was preserved in a well, a good environment. But the recent studies have shown that a significant amount of growth factors are released during the first 20 minutes after preparation. Hence, it is said that they should be used as quickly as possible. So the time factor is very important. Now, if you were to look at the use of this PRF, these can be used in the protection of a wound, stimulation of healing, and also used in the situations where tissue repair is very poor. It can be used in the form of a cloth, membrane, injectable liquid, can be used in a plug form. It can be cut into small fragments and it can be mixed with the bone graft, etc. So, having said this, we are coming to the final part of my presentation. Now, PRF is being investigated and it is being used worldwide by a lot of clinicians as an adjunct to promote bone and soft tissue healing. Now, this product has grabbed the attention of clinicians mainly because this is a biomaterial that is easy to prepare and easy to use. Now, with lot of variations among the PRF names and centrifuges, yes, it has created a dilemma again among the clinicians. Now, one of the limitations of PRF is its heterogeneity. But we need to understand that irrespective of the protocol, successful outcomes have been reported. As I mentioned earlier, at present, there are no randomized controlled trials that has been done to compare the different protocols in order to claim superiority or inferiority of this product, which means that PRF technology is still in the state of infancy. And this can have a big impact in dentistry if more clarifications and evidences are provided. So, now that we have recognized the magic potion within us, it is left to each one of us to work on this concept by following a good standardization on this protocol. I would like to end my presentation with this quote. You can never make the same mistake twice because the second time it is not a mistake, it is a choice. Thank you.
Yes, thank you, Prof. Betsy, for the wonderful presentation. So, I we have very one question here in the chat box. So, the question was asked by Bharati Pujari. Hello, ma'am. A very informative session. I have a question on the need to cover PRF when placed in extraction socket.
Actually, there is no need. Now, if you are looking at the protection, there is no need because PRF itself has got antibacterial property. So you don't have to worry about PRF getting infected. Now, if you're the only thing which you need to look at it is we need to stabilize it in the initial stage, that is in the first day. For that, you can stabilize it with the help of sutures. You know, you need not even suture the PRF clot. You can give a mattress suture wherein this is kept in place. After, say, for example, after the second day, you will find that this PRF membrane is very well glued to the underlying tissues. So, if you're looking in terms of coverage, actually it is not required. But this is actually this PRF membrane is being used along with other collagen membranes as a protection. So, in case of extraction wounds, you need not cover this.
Okay, I hope Bharati got the answer. Uh, so thank you once again, Professor Betsy, for an enlightening webinar on the platelet concentrates. So no more questions over here. So thank you so much.
Thank you.
I would like
Thank
to
you,
request
everyone.
all the viewers. Yeah, I would like to request all the viewers to stay tuned to the Masa University Facebook page where we are going to update our upcoming webinars. So stay tuned to the Masa Facebook page. Thank you so much for joining us. We will see you soon. I'm sorry, Professor Betsy, we have one more question from Dr. Padmini. Um, any comments on influence of blood drawing protocol?
Platelet drawing protocol, as I told you, the handling property, yes, we have to do it fast. What they say is that the collection, the centrifugation, and the use as fast as you can. They say that it has to be done within 1 minute. The studies have shown that as the time increases, the effectiveness of your product decreases.
Okay. So no more questions, Professor Betsy. So shall we end the session here?
Thank you. Thank you,
Yeah.
everyone.
Thank you so much. Yeah. Thank you.